Hello, this is Dr. Nelson, and this presentation is designed to highlight certain features of the oral anatomy that you should be familiar with when doing your oral examination exercise today. Previous years, we have actually put on our PPE gloves, masks, and protective eyewear and actually identified oral structures in the simulation lab. Obviously, for the COVID-19 restrictions that we have now, we're not going to be doing that for this year. Looking back on it, this is probably not a very strenuous exercise for most students to do because the Wolfel and Sheed dental anatomy textbook has a diagram already labeled and ready to go for this. You should be familiar with these structures and be conversant with them after today, so this will be a good exercise for you to warm up with, even though we will not be doing the clinical examination in the simulation lab today. So in this clinical slide, we will discuss the difference between the anatomical crown and the clinical crown. Dr. Chung has already discussed this with you briefly. The anatomical crown is that portion of the tooth that is covered by enamel. And the crown, or the anatomical crown of the tooth, is delineated from the rest of the tooth by this structure here, which you already know is called the cemento-enamel junction, or the CEJ. The clinical crown is that portion of the tooth that is visually from, as we're looking into the mouth. And in this situation here, this is the CEJ of this upper cuspid, and you can see that the anatomical crown here is fully exposed. In a healthy gingival periodontal patient, the CEJ is normally covered by the free gingiva and it is not exposed. So in this case, we've had some gingival recession, loss of periodontal support and structure, which has led to this tooth becoming longer, basically, and the clinical crown is actually then much longer than the anatomical crown. In a healthy individual, the CEJ is covered by the gingiva, and so the anatomical crown really can't be fully seen, and so the clinical crown is actually shorter than the anatomical crown. Now, let's look at this patient with mandibular anterior and posterior teeth. If we look at the premolar here, the first premolar, you can see that this is a little more healthy situation than the last example we were using, in that the anatomical crown of the tooth is not fully visualized. So the clinical crown here is actually a little bit shorter than the anatomical crown. The gingiva that you see here is divided into two different types of gingiva. There is the attached gingiva that you kind of see down here. It's got the stippling on it, should be a uniform coral pink. And then an area that's called either marginal gingiva or free gingiva, which is usually 2 to 3 millimeters above the attached gingiva before that in the tooth. If we take and section this tooth in half, like that, and then look at that section from the proximal view here, this is what the diagram would look like. So we're looking here at the section tooth which has enamel. This is the cemento-enamel junction here. This would be the root of the tooth covered with cementum. And we see the two types of gingiva in this diagram. We see the attached gingiva, which is this material here, this tissue, that is uniform coral pink again and somewhat stippled in a healthy situation. We have a free gingival groove which separates or delineates the attached gingiva, which is here, from the free gingiva or marginal gingiva. The terms free gingiva or marginal gingiva are synonyms, so you can use them interchangeably. The free gingival groove that you see here on this diagram might possibly be represented by what we see here in this lateral incisor tooth. that's there. That might be the free gingival margin on that, or the free gingival groove on that patient. Hard to delineate a groove here. In some cases where you have local inflammation of the marginal gingiva, the free gingival groove will not really be shown. Now there is another structure here that we have to talk about, which is the free gingival margin. The free gingival margin is the crest of the marginal gingiva, and that is actually what delineates then the anatomical crown or delineates the clinical crown in this instance, I'm sorry. This diagram, the free gingival margin, is that part of it right here, which is the crest of the gingiva, right at that point. So we have attached gingiva coming up here. We have the free gingival groove. Then we have the free gingiva, or the marginal gingiva. And the very crest of that then, which delineates the clinical crown, is the free gingival margin. Now if we go internally from the external aspects of the free gingiva, you can see a structure here that is, the free gingiva is kind of held in tight approximation to the enamel of the tooth, but there is a little space there which is called the gingival crevice. The gingival crevice is lined. It's actually movable. You can kind of move the tissue slightly with a probe, gently moving it. And at the base of that then, the epithelium is attached, called the epithelial attachment, to the enamel of the tooth, or wherever the root of the tooth is at that point in a healthy state. So from internally, if we're looking at the gingival crevice, or sulcus, gingival sulcus, we have the free gingival margin, we have the gingival sulcus that is down, goes down here like that, and then it ends and terminates in the epithelial attachment, which actually then seals off the periodontal area of the tooth, periodontal membrane, that you'll learn about later in periodontics. Now let's start from external and discuss the entry to the oral cavity, which is the lips, or sometimes called the vermilion border. At the corner of the mouth, we have the labial commissures, and that's the corners of the mouth that you see here. This material here is keratinized skin, right? So we have the regular keratinized skin, and then we come to an area beginning here laterally at the labial commissures, which is an area delineated called the vermilion border. Vermilion is another term for red color, so this is the red border, and you can see that the tissues make a transition from the keratinized tissues of the skin here to the non-keratinized mucosa of the lips, and then as we go in, we'll go into the interoral mucosa. There's two different definitions for the vermilion border. One, which is probably more currently held and more popular really, is just the vermilion border is just that area where the skin and the mucosa of the lips makes the attachment there, or makes the transition. So that would be the red border. And anatomists will sometimes refer to the vermilion border as that area that would be occupied by, or worn by, lipstick or whatever. So that would be the entire lip area there that you'd see would be termed the vermilion border. So not to confuse you, I'm just telling you that there are different definitions of vermilion border in consideration. One is just the very red border, and then the other is more the area where lipstick would be worn, or chapstick would be worn, and would be considered the whole area as the vermilion border. If we ask our patient to reflect their lip so that we can see the aspects of the oral mucosa, you can see that there are numerous little blood vessels in there. The tissue is much less tough. It has no keratin in it, so it's more fragile. It's moist. You can see oftentimes little yellow labial glands in here, sebaceous glands that may be present. In some cases, there will be Fordyce spots, which are unique structures that you'll learn about more in pathology. But If we were to do this on a patient, we obviously would have to have a glove on and we'd have our mask and full PPE, but we can ask our patient to help us out and see this a little bit by just having them reflect their own lip. And this is probably what you'd see in a normal, healthy patient. Wouldn't just be pink, you'd see areas where you have little yellow or globular salivary glands or mucosal glands that are in the lip area. Now let's go into the oral cavity by reflecting the cheeks, and you can see what is called the oral vestibule. The oral vestibule is that area, that space, that is bounded by the internal aspect of the cheek. And then on the internal aspect of it, from the alveolus, the buccal surfaces of the teeth, and then the internal mucosa of the alveolus, called the mucogingival junction. You can see here that's very, very striking in this patient, the difference between the mucosa down here, which is unattached, and then the attached gingiva that you see here, which is a nice uniform coral pink. Again, we see the free gingival margin as being the crest of the free gingiva, and you have the attached gingiva from here to probably about there, and then the rest remaining on top would be the gingival margin or marginal gingiva or free gingiva. The mucobuccal fold is the areas where we make the transition from the alveolus here to the oral vestibule, as you can see. So there's an inferior mucobuccal fold here and a superior mucobuccal fold here. Again, you can see the same thing here. This would be the inferior mucobuccal fold, and this would be the superior mucobuccal fold on this side. So the oral vestibule is that area that's outlined by the cheek, internal portions of the cheek, and the outer portions then, of course, of the alveolus and the enamel and the buccal surfaces of the teeth. In the mucobuccal fold that you can see here is and these are called frenula. Here is the superior labial frenula. They're muscle attachments. Here is the inferior labial frenula that are in the mucobuccal fold area that attach to the alveolar process. You can see there and there buccal frenula on the mandibular arch. Will sometimes occlude together. You will see an area that's either from cheek chewing or from rubbing on the buccal surfaces of the teeth, but you'll see an area here that is called the linea alba. What that means is a white line, and it's just an area kind of where the oral cavity gets calloused from rubbing against the occlusal surfaces of the teeth. Other times patients will have the external orifice to the parotid duct that would be called the parotid papilla, that is sometimes next to the first and second molars, that will be rather prominent. In this case, it's not so much. You can see the muscle pull here of the buccal frenulum, and just some items of interest in the oral cavity for you to visualize. And of course, not to beat this up any further, but we can see in this particular patient, we have the mucogingival junction, which is here, and then you see the uniform coral pink of the attached gingiva. This probably would be the free gingival groove that you see here, and then we have the gingival papilla that occupies the interproximal space, or as Dr. Chung was mentioning, the lingual gingival embrasure. This would be the buccal gingival embrasure here. Is occupied by the gingival papilla. And yeah, I guess that's about it for this one. Intraorally, if we ask our patients to raise their tongue, we might need to duck a little bit because we can get leaked, but we have the sublingual caruncles, which are the orifice for the submandibular glands, which are very powerful salivary glands that are under the tongue. and they can kind of shoot out at you, so you got to be a little careful about that. And of course, we have the lingual frenulum, again, the muscle tag that you see here. It's much like the superior labial and buccal frenulum that you see, they're muscle attachments. Very strong one on the internal side of the tongue, called the lingual frenulum. And on either side of those then are the openings to the duct, which are the sublingual caruncles. If we grab a hold of and take a look at the tongue, you can see that the surface is rather rough. There are many different types of lingual papillae, which are papilla, which are the filiform papilla are these little hairy structures that are on the side of the tongue. And then you see some red ones that are a little more rounded, and those are the fungiform and lentiform papilla. They sometimes have some little taste buds and stuff in them. And then on the side of the tongue, if you can pull them out, there are foliate. These are vertical papilla that are on the side of the tongue. And then way in the back, you'll see there is a section of these papilla that are raised. And they look kind of ugly sometimes, and some patients will think of them as being cancerous. But those are the circumvallate papilla. They're perfectly normal, and most patients will have them. Another view of the circumvallate papilla from back here. And I have actually had patients notice them for the first time when they're maybe, looking at their tongue or something and wondering if they're cancerous or not. They form a definite V pattern at the base of the tongue, and they're perfectly normal structures called circumvallate papilla. Now, as we end our tour of the oral cavity, we're going to look at the maxilla, and we have the palatal structures. If you ask the patient to say ah while you're looking at the palate, you'll see there's an area that will kind of be movable, and that's the soft palate. And then the other area here, as you put your finger and push, will be fixed. So it's definitely a rigid structure. We see these structures here that we call rugae, or transverse palatal folds. We have a structure here, which is the exit to the nasopalatine nerve that comes out here and supplies it, sensitize sensations from the anterior palatal area. It's also the part that hurts so bad when you burn it with a pizza or whatever. But that's called the incisive papilla. And the palatal rugae is in mid-sagittal plane, as Dr. Chung was saying, are the areas where the palate fuses together down the midline. And finally, the last structure that we have is the uvula, as you can see here. That's the area right in the center. As the patient says ah, that area should move uniformly up and down as the patient moves their throat and the soft palate. You may also see some very strong structures back here that are the palatine tonsils in your patients, but we'll reserve that for when you're actually in the clinic, and we can point those out with a little greater detail. I know that Dr. Chung has made some exciting changes in your color cast exercises from what you have, but you have a set of casts that the laboratory staff poured up for you, and you'll use those. And it will ask you to draw specific lines in specific areas. So if it asks you to draw a line from the mesial surface to the distal surface on a lower first premolar, that's how you would do it. So try to be very, very specific in following directions. And if you're not sure what those are, then come and ask the faculty. This is why we have these exercises for you to do. We do have colored pens or pencils available for you at the dispensary. You can each have a couple of different colors. It doesn't really matter what color you want to use, but just be consistent as you're going through. Just use the colors that you have and try to learn from the exercise. And this is me receiving my appointment at the Nankai Medical College in Tianjin, China. We have a sister school relationship with that, and I very much enjoyed my time teaching the Chinese dental students there the same material that I'm teaching to you. So good luck on your year this year. It's going to be very busy. I know that we've thrown a lot at you this first day. You'll be able to go through this and become more comfortable with it with practice. But again, like learning a language, we're going to hold you to using the language. So if I ask you to actually point at a structure or say something that is, we're not going over here, whether we're going mesially or distally or whatever. It's just to give you an opportunity to practice the new language that you're learning.